and I would like to present this lecture talking about the basic B-scan examination, how you can conduce a basic B-scan examination, and you can take advantage for your machine, your presentations, your images, and especially if you have the right instrument. I mean, if you have the right instrument, if you have the right ultrasound device, you can get the better images. It's good for your patient and also good for your colleagues. Then, okay, let's see. In the very beginning, we must be sure what are we doing with the position, how to manage the eye anatomy. When you use the machine, you can look for inferior nasal and temporal part for every eye, and you can recognize as soon as possible which eye are you examining. This is so easy when you are in front or you are facing the patient. Some people make the ultrasound examination just with in the other in the other position, in the opposite position. You are in the head, and the patient lie down with the feet just in front of you. Then you must be sure what you're doing, and then you can talk not only in superior, inferior, nasal. You can tell when you describe the lesion, when you describe the pathology, use the time, hours. The lesion is a 12, a 1, a 2, etc. And we would also say it's anterior, posterior, or intermediate. We will see that in order to be clear, sometimes you make the examination and you are not sure where is the lesion. And so if it's a retinal tear, you must show the situation of that to use to make the best treatment. Okay, in B mode, we have a compound of a lot of A scans. You see that it's different to biometry because biometry is one scan. In B mode, there are scans that you cut in one part that is reflective, is white, that is low reflective, is black in the screen. But the most important thing is to know how to manage the eye anatomy. The probe has always a mark. This is a white mark, and this is the way that the transducer runs inside the probe, and the ultrasound beam is conduced in that form. And this mark is in this moment facing, if you are in a clock, tell me what time is in the marker, and you can easily say that it's 3 o'clock. This is very important because if you see that, that means that you are seeing the image in the part of the screen is 3 o'clock. Okay, let's go. Then this is you must recognize pupil, cornea, limbus, sclera in the anterior and intermediate segment. And also, when you are doing ultrasound, you can recognize macula and optic disc in order to describe of the pathology. Okay, there are two landmarks of the image, the optic nerve and the macula. And try to keep the macula always in temporal side of the optic disc. In this way, where are you if the pathology is in the macula or near the macula. This is very important, for example, in a cataract surgery or in another conditions. Also, if you have the transducer and the patient is looking up, you can see when it's up and down, you must recognize that. In this case, we can recognize it's a right eye or left eye. I can see it's a right eye. Okay. Macula is always in the optic it's on temporal side of the optic disc. Okay, let's go. The ultrasound beam is like an scalpel. It makes cuts or shots, can see there are 2, even 3 positions that you can get the information: transversal, longitudinal, and axial. We will see what happened, and you can see that in transversal and in longitudinal, you avoid to pass through the lens. Only in axial approach, you pass through the lens. What happened with the lens? With light, there's a converge. With ultrasound, it diverges, and there is some distortion in the image. If you want to see something better, try to don't pass through the lens. The way you can pass through the lens is to make B-mode biometry, and we will see in the next lecture. Okay, let's go. On Prof, there is a white marker. There are 2 cases, the 10 and 20 and the linear 25 or linear 50 megahertz. This is the 10, and you can see there is always a mark. What does it mean? If you have a mark, the ultrasound beam has this shape. The mark is here, and the ultrasound beam has this shape that you can see very easy in your screen. And this part is superior. That means it doesn't matter what is the position of the eye, but you are pointing in the superior part will be in the mark part will be up, because the ultrasound beam runs in this direction, up in the screen, down in the screen. If you change it, you can see the inferior part, but if you turn your Prof to the inferior part facing this point here, will be up and down. You can understand that? It's very easy, because if you keep your mark superior or nasal, pointing superior or pointing nasal, you will always have the same images, and it's so very easy to understand which part of the eye or the orbita are you making the exam. The marker then corresponds with the top of the screen. Okay, if you make it this, this is the mark up, pointing to the cornea, in this case the lids of the cornea. In the upper part of the screen is nasal, and in the lower part of the temporal. Yeah, right now, if I face it to your eyes, it's very easy to understand which position is the Pro and which is the position in the screen of nasal and up and down if it's the case. I can use the rice bowl just to show you what happened. When I teach my residents, I make this very easy. It's very easy to understand when you use this rice bowl. Our problem is how to teach our residents and fellows a basic scan and B-scan screening position. And this is a cheaper and ridiculous simple solution, because it's an important skill is to learn transversal and longitudinal scans and then translate these images in 3-dimensional diagnostic interpretation. We introduce a simple, didactic, and accessible method for teaching this, using the simplest, effective, and straightforward way for this. They was in Scotland. This was the CDUO meeting in Scotland. There was many things to show in Scotland at the time. For example, Ronald Green was showing the legs. Everyone was there. There was many things to see in Scotland, and they present us a 3D presentation. They in Edinburgh in 2010, and this was a paper called a visual tool for teaching. The Medical College of Life Science and Medicine University, they spent a lot of pounds to make this computer system It was incredible. It was a computer system, a 3D recreational. At that time, it was fortune. Nobody wanted to lose a single in that 2000%. Really brilliant, but too expensive for the countries. 4 years thinking for the next CIDO, we decide too much money to invest. We try to look another solution, and we have a problem, and then we solve the problem, making a Chinese food mall and indelible markers in various colors, and pointer and a laser label, dots and sheets of plastic film, an eraser or whatever, and then we develop a simple chip and actual three-dimensional model to make sense and the radiation of the ultrasound beam. Let's see. Let's go to the demonstration itself. Okay. This is the board. If you can see it, okay, this is mirror image, then you can see this is the rice bowl, and I draw there, and I draw all the vessels and macula. And then, on the other hand, I use a level, and you can see it in my, okay, you can see. And make this just to understand the process. When I put this in the part of the image, and I make the movement in this position, this is horizontal. I am scanning the upper part of the eye. That means the superior part system is the inferior part is 3, and in the middle is 12. It's like a clock. Then this is the transversal scan. I can do also a longitudinal scan. Look, and the anterior part, yes, is the upper part of the scan is anterior, and the most inferior is posterior. And this is the difference between a transversal scan that I can go for 9 to 3 to longitudinal scan. This is only 1 hour. In this case 12. And if I want to go to the macula, I can go a little bit center or nasal. Then, if you have this is so easy, you can practice the position of the ultrasound, and you can make transversal and longitudinal and also axial. Okay, at the moment it's very difficult to make an axial because you can't see anything. Then it's a very easy way to understand you are scanning. If you are transversal, in this case, you are longitudinal if you are this way. Then to do it in the screen because it's a mirror image, but if you have a tumor, for example, I use an eraser and I put the tumor here. Look at the tumor? Yes. Okay. I can see, can move another, okay. When I make it this way, I the tumor in the superior part of my screen, and then I make longitudinal screen, and I have the bidimensional part of the. It's very hard because I'm doing opposite. Is to make okay to be sure you can be a longitudinal approach to the tumor, and you can do a transversal tumor. Since this is something that you can learn, very well using this model. Okay, let's go to the present just to show what you see when you are doing this. Okay. If you put your probe, the macula is temporal in from the optic disc, and you apply the marker temporal, then you can get the macula, the screen displays above the optic nerve. If the macula is the temporal part, the opposite, I mean, when you put the marker to the part, the macula is below the optic nerve. It's so easy. You must remember what happened with the mark, but it's up in relation to the mark in order to get a better relation. Then the macula is temporal from the optic nerve. Was the temporal or nasal? Can you tell me that? It was temporal. Yes, easy to understand. Okay. Do step by step the beam mode. The patient must recline with the head between examiner and screen. You anesthetize with oxybuprocaine in the two eyes in order to make compression. You apply ophthalmic gel on the eye or in the ear or 10 in order don't miss the ultrasound power through the absorption. And then patient pin, I have a light in the ceiling. I look the patient and I look the screen at the same time. I can make a very comfortable to me. I can perform a lot of examination during the day, and also the patient is comfortable. If you make it the patient in the other side, I mean, with the head in this position and the foot in the other part, you must change all the things, and I not agree with that. I prefer to do my examination that way. How to handle the Prof? You have a grip, and you need to have smart in the upper part, temporal part. You should be, and you must be perpendicular. If you are perpendicular, you send the ultrasound beam and you receive the ultrasound beam complete. Not perpendicular, you miss a lot of echoes and you miss a lot of information. Oh, I told you, we always at the opposite part of the eye. If the Prof in the nasal part, we see the temporal. When you see it this position up, this the other side of the eye. The only part you see that is in the axis position. Okay. You must put the probe up to the area. If you are sure there is a lesion at 12, or you make fundoscopy or something, you patient to look away from the probe in order to rotate the eye and give the optimal scanning range. And the entire eye must be scanned transversally if necessary, actually. Let's see that. If you are in this position, you put the position in one part, 3, and then you move it to 8 in order to cover all the posterior part. If you put it tempered, you are looking nasal and vice versa. Okay, but you must move it. This is not an examination in one place. Okay, let's see. Now the marker is at 4, and the question is the temporal side at 6, 8, or 10? If the marker is at 4, and this is nasal, is temporal, the down part of the screen. That means if you are making that, it's at 10 o'clock. Easy to understand. You must be perpendicular to the examined area. For the transversal and longitudinal scale, you must avoid the lens which absorb the ultrasound and diverge the sound. It's correct when you pass to the lens, you see all the information. If you look, you are examined, you have more place in this area to make the correct examination. For example, you have a funnel-shaped retinal detachment, and you put then you get this image just because you are trying to do you're trying to do the examination in a form. When you change it and ask the patient to move the eye, you can just in the middle, and you can see this area like a circle. This is because you change the perspective of scanning. Look, if you are in this position, you can do this funnel retinal detachment, and you just in the center of the retinal detachment. This is transversal scan. There are many positions, and look, the probe is parallel to the limbus always, and then you can see superior A because there's a white mark here, and inferior B. Let's see again. For the transversal and longitudinal scan, the patient looks toward the examined area to bypass as much as possible the lens, because the lens has some distortions. Then, in this case, you want to see the nasal superior part. The patient looks toward the area to be examined, and the probe is applied in the opposite area. And then, if you get something, you can see that the lesion should be in this position. At 1:30, as we talk. You can do it. It all depends what you want to make. So if it's very anterior or posterior, you make longitudinal. And at what hour it's located, you could make the transversal. Okay, most of the time we know the examined area. The patient has already made a previous examination, endoscopy, OCT, etc. For example, a tumor on the left eye at 10:30, it means nasal superior. The scan is 3 sections: transversal or limbus-parallel, longitudinal or radial, or axial. Okay, let's see. Transversal in this case, longitudinal or axial. The examination always starts limbus-parallel, that means transversal. Transversal or limbus-parallel is the patient looks against toward the area to be examined, and the probes and opposite. And always the mark should be facing up or nasal, always. Yeah? If you make the marker is always directed to the top or to the nose in the superior or nasal, always. And then when you do that, you can use all these positions, and the marker should be nasal or superior, superior, nasal or superior, nasal, nasal, superior, superior, nasal. Always, if you make this, you make the examination in the same way, and you can be sure whether you do it. Okay, the tumor is at 12 o'clock. You try to see it on top, on right eye. The patient should look up and you get a probe eye button and on limbus in this form. The patient look up, you put the transversal scan if you want to see a tumor or a lesion in 12 hours. Okay, if you know that the lesion is at 3 o'clock, nasal, right eye, you make the same. The patient look nasally, that means to his left. The probe will be put temporal on limbus, and this is the way I can show you. You are always opposite. It's so easy, but sometimes it is very important to point at that. Down in temporal 7 o'clock, what do? The patient look down and on his right, that means temporal. The probe apply close to the nose or on the top. This is the way. that you make. Also, this eye should move in the images. It's not possible, but you notice that. The transversal. If you see transversal, up 3 o'clock, down 9 o'clock, and in the middle is 12. It all depends how you change the movement or incline the proof to see more anterior or more posterior by the movement. And this is the same. You can, as an asking a question to you, you have an inferior nasal tumor in the left eye. This is the left nose, and you have a nasal tumor inferior. How to position the right way approach? Which one we can choose? This is correct to make the examination. Okay. Transversal, again, the patient looks toward to the area to be, the from limbus and opposite, and marker is always directed to the top or to the nose, superior or nasal, like this. And if you move where you are very near and very perpendicular to the eye, you are facing the posterior pole. If you go a little bit down and change the inclination of the proof, you are in the equator. And if you continue moving the probe, you can go to the periphery or very anterior part in transversal scans. Okay, again, the very, very beginning, up, you're in posterior, then equator, posterior extreme, posterior near to the equator, and near to the equator, ora serrata, ciliary body. You can also in your screen which position do you find the lesion. These indicators are used to estimate the scan angle. The scan is more or less anterior to the ora serrata, posterior near. Okay, this is the transversal or limbus-parallel. And then the second, longitudinal or radial. That you change the position of the probe and you put the mark facing the center of the cornea. And then you are making an examination that always in the upper part of the screen is anterior, and in the down part is posterior. Anterior, the insertion of the muscle is always anterior, and the optic nerve is always posterior. It's easy to understand. Then, again, the patient looks toward the area to be examined. The process limb and limbus, and in the opposite side that you are looking for, and the mark is facing the center of the cornea, directed to the center. Okay, if you have a tumor at 3 o'clock, nasal in right eye, you must do follow. The patient looks nasal again to his left in this case. Your proof should be temporal in the limbus and the position. You are doing a longitudinal difference. It's always pointing the center of the pupil center of the cornea. Again, if the tumor is in this situation, again, the patient looks down and nasally to his left. The probe is in temporal and to the top. And the marker should face the pupil center in this position if you want the tumor nasal inferior. And look again, in this case is a longitudinal or radial. You don't see the sides, you see only 12. When in the scan, the superior part is always anterior and the inferior part is always posterior. And you can see a retinoschisis, a tumor or whatever in this position. And at the last part, we can make the eye examination. You put the patient look straight away, straight ahead. The probe is centered to the cornea, horizontal, vertical, or intermediate. And it all depends If you put it horizontal and the mark is always nasal, up will 3, 9. The same case here. If you make an axial shot, up will be 10, down will be 4, etc., etc. Again, axial is 12, down is 6, and you can see the lesion in which is near the 12 o'clock in this case. This is very useful in the biometry B mode. We will see in the next presentation. Okay. Then, if you have a tumor at 12 o'clock, again, transversal. Okay, good. The mark is pointed to the nasal, and then we get here 9 o'clock, at 12 there's a tumor. Good. If you made the longitudinal, we see in the same facing also 12 that the ocular is down, and the lesion is more near to the insertion to the muscle than the optic nerve. I mean, it's equatorial or pre-equatorial lesion. And if you make it axial, you can see it this is more up, and the optic nerve is in the middle. Easy to understand in that way about the position. It sounds very, very easy, but in fact, it's very difficult to make it during the examination. You must know where is the lesion, because it depends how it will happen. Okay, let's see again. There is a tumor at 10:30. Which one is the image? Good. Yes. You longitudinal, which one is the correct? Yes, the first one. And you axial, which one is correct? Yes, the first one. In that case, in these three positions, you can be sure you are examining a tumor at 10:30. Okay, look again. It was at 10:30. This was the transversal. Look, this is longitudinal. Look, the muscle insertion, and look in the axial, the position relative to the optic nerve. This is the way we make a full eye examination, transversal. Look again. You can get these tables by Sunil, by Quantel. We have these tables in Lima. You can get the file and you can print it for you. And you have the how is the transversal and the longitudinal and axial approach to the eye. Oh, sorry. Always, when you begin the examination, try to start with a medium gain. 80 decibels is the tisular gain. Increase and decrease the gain. Don't be fixed in one gain. You must go up. You can see better the vitreous when you have a medium or high gain, and you can see better the posterior pole with the less than 90. Again, if you are using transversal scan, you must center the lesion, and you be sure in between which area. I mean, this lesion should be in between 12, okay, 10, 11, and 8 or 7. Then it should be just in the middle. The 10:30 should be located, this lesion, and you'll be sure because you see the margins of the lesion up and down in the screen. And when longitudinal, you always have a optic nerve and muscles. Okay, what's the pathology? Because we are very look. If you are very, very anterior, you can see we are transverse, but very anterior, the pupil moving is very, very extreme. You can achieve also the anterior segment, or also you can see an intraocular lens. You can see also the pathology. In a transversal scan, you can see the movement of the vitreous, and you can see in the posterior vitreous detachment and subhyaloid and vitreous. You can see this movement, and this is a longitudinal. Look, the optic nerve is down and the muscle is up. It's easy to understand when you make always the same routine to make the examination. Again, this is another transversal. This is a vitrectomy in just the middle of the vitreous was operated. There is a part of the vitreous is totally there. This is vitreous kisses, separation between the two layers of vitreous. This is no retina. This is not attached to the optic nerve. Then you can see posterior vitreous detachment, because this is not retina in the A mode, in one eye with silicone or remnants. You can see dense hemorrhage vitreous and subhyaloid hemorrhage, very easy. This is a transversal scan. This is another vitreous and subhyaloid hemorrhage, and also you can do a scan. This is another examination. I can show you that. This is Asteroid Hyalosis. Look this, and look at the optic nerve. I mean, I'm doing, this is up and this is down. This is right eye. It should be 12, 6, and the optic nerve should be at 3. It's easy if you understand the positions. Another asteroid hyaloid and posterior vitreous detachment. An intraocular foreign body is important to see in which part you can use the optic nerve just to locate how near to the optic nerve is the foreign body. And this is a toxoperiasis in this case, and also this case is typical. This is the optic nerve. This is a longitudinal look. This is the optic nerve here, and this is the insertion of the muscle. Even here, optic nerve, and this is the muscle. This is a longitudinal scan. It's easy to understand that. This is a persistence of hyaloid artery in that case. The retinal pathology, the retinal tear is very important to locate the exact position of the tear in order to make the laser treatment or the surgery. And you can also say in which position and what happens with the anterior part. Look, again, this is a longitudinal in order to get this peripheral vision. If the retina is elevated in the borders of the tear. Okay, retinal tear bigger. You can see also for retinal tears, it's very nice the longitudinal approach. Retinal detachment total, another with cysts inside, another it says retinal detachment fractional due diabetic retinopathy, and also fractional is very common with diabetic patients. Again, this is retinal dialysis because it's broke in the very peripheral area, and it seems to be in that way. And retinal detachment plus in scleritis and tendonitis with myositis is very easy to see. And this is again a longitudinal screen. The optic nerve is here, and the muscle insertion is up. Okay, retinal detachment and posterior ifema. Hemorrhage is a dengue hemorrhage, retinal dengue patient. Subretinal hemorrhage also in the sublimitant intern, you can also see very well. And in ocular tumors, yes, in the very beginning, the problem is if you use only B mode, you can recognize which one is the melanoma, the hemangioma, or the metastasis, because they look very similar. If you make standardized, you can see that melanoma is low reflective, hemangioma is high reflective, and metastasis is medium reflective. And you can make the diagnosis easily, combine your B scan plus your standardized A mode. Then this is a malignant melanoma with internal vascularization. You can see it here, and you can see it with the standardized mode very easy. Exophytic, you can also see with B mode that the tumor is not only intraocular but also extraocular in the orbiter, and also in A mode you can see the intraocular part and the postocular part in that patient. And choroidal hemangioma, if you see, this is also dome-shaped tumor, but the A mode is not low, but it's very high reflective. This is the difference. In B mode, they look very similar. In A mode, they look different. Metastatic carcinoma, also the same. It's a bump surface and medium reflective to high reflective in a metastatic carcinoma. Retinoblastoma, you can also intraocular calcification. Here is very low calcificate, and the A mode also is very regular, and you can make very easy in B mode the diagnosis of retinoblastoma. Again, calcification inside the eye in child is retinoblastoma until you see different things. And in the very end, choroidal detachment, the kissing choroida, hemorrhagic intraretinal microcyst in an old retinal detachment, and intravitreal fixated lens also is a tumor that moves. And you can see it very easy. And cystic circles, you can see also, we look for cystic circles, look the movement of the membrane and also with the scolex of the patient. Beam mode is very powerful tool to make diagnosis. Okay, this is the first presentation. We took 20 minutes exactly to do the presentation.